Hi, everyone. This is Rachel, the project coordinator for our Early Psychosis Learning Collaborative. Please feel free to introduce yourself in the chat box. Next slide, please. I just wanted to review a few housekeeping items with you all before we begin. Participant microphones will be muted at entry, and you'll be able to unmute them during the discussion portion. And during this presentation, if you have any technical difficulties or questions about the topic, please use the chat box. The session is being recorded and will be available for viewing at a later time on the MHTTC website. And to reach us after the webinar, you can email newengland@mhttcnetwork.org. Next slide, please. And this slide provides a description of our disclaimers for MHTTC. Next slide, please. And the MHTTC network uses affirming, respectful, and recovery-oriented language in all activities. That language is strengths-based and hopeful, inclusive and accepting of diverse cultures, genders, perspectives, and experiences, healing-centered, trauma-responsive, inviting to individuals participating in their own journeys, person-first and free of labels, non-judgmental and avoiding assumptions, respectful, clear, and understandable, and consistent with our actions, policies, and products. And with that, it is my pleasure to hand it over to Dr. Macheri Keshavan for introductions.
Thank you, Rachel, and good morning, everyone. It's my pleasure to introduce today's topic on our regular Psychopharm consult series by the MHTTC. Some of you may have previously participated in this recurring series where we take one or other topic in psychopharmacology and in an interactive way discuss the implications and application of the cutting edge principles of psychopharmacology into our practice. So the topic of today is what we call measurement-based care in psychiatric practice. The one thing that I would say by way of introduction is that, in the rest of medicine, doctors use either a stethoscope or a thermometer to measure the temperature or the heart rate, or they use the sphygmomanometer to get the blood pressure when they're treating hypertension, or another medical condition. And in psychiatry, we do not have such simple, straightforward biomarkers at this point. However, we do collect information which is quantifiable in terms of behavior, which is what we treat and which is what we assess and measure. And so there is a tremendous value to a measurement-based practice, which improves our ability to monitor and provide effective care. So today we have an expert in this area, Dr. Rajiv Tandon, who's a friend of mine for over 4 decades. He's a professor and chair of psychiatry at Western Michigan University in Kalamazoo. And he is, thankfully agreed for us to have him as our expert presenter, who will give you the principles of measurement-based practice and take you through some actual case examples as to how one can incorporate these in practice. So Rajiv, take it away with that. Thank you.
Thank you, my friend. Now that you've already dated me 4 decades, I would share with the audience that, Dr. Keshwan has looked younger each day that I see him over these 4 decades as I have aged. So with that, thank you for inviting me, Kesh. And when Dr. Keshwan asked me to present on this topic and discuss this with you, I asked him, well, tell me a little bit about who's going to be on the call. And when he shared with me who was going to be on the call, I said, but Kesh, these are all experts. They see patients all the time. They know as much about what to do, how to treat patients as I might. And so this is going to be more of a conversation. This is going to be more of a discussion. And please, I would request each one of you to participate in this. There are a number of questions that I might pose. as part of this conversation. There'll be some clinical scenarios that I will present to you and ask you about what you would do if you were to encounter a clinical situation such as that. So please, your contribution, your participation is, in my mind, even more important than what I may have to share with you. With that, conflicts of interest, no financial conflicts of interest, but since Dr. Keshwan has already shared the fact that I'm an old man now, I've been a practicing physician for over 4 decades, and I bring to my thinking the biases that come with being a physician, but with being a doctor. Essentially, I want to see my patients get better, each one of them. I do everything I can to help them get better. I don't like complicated information. I don't like speculation. And whenever I'm listening to any expert, one of my pleas to them is, give me the simple information in a very simple, straightforward manner without waving your hands, if you will, because whatever you share with me, I'd like to apply this information to the care of the next person who walks into my office seeking my help. So those are my clinician biases. Now, one of the downsides, one of the things I have had to kind of, wonder about as a clinician and remind myself is in my enthusiasm to help people get better. Sometimes I'm doing things that might actually not be helping them. Sometimes I might be doing things that might actually be hurting them. But in my exuberance and desire to do everything and anything I can to help them get better, maybe, and my desire to see them better, maybe that's something that I might miss. And so that's my clinician bias, if you will. And as a researcher, I look for data. I look for data, information. Now, I'm also cognizant of the fact that, if I pick and choose what information I present to you, I can tell you almost any story I want to. So it's really important to look at all available data, critically appraise it, and then present it very simply. No hand waving. The clinician in me wouldn't want that. So I just wanted to share those biases with you, or the way of thinking with you, because I think you might see them reflected in the course of our discussion. And the other conflict, if you were to describe it as such, is the fact that I was a member of the DSM-5 work group on psychotic disorders. And as I will share with you, there are some useful tools in DSM-5 that might help us do better for our patients. But you'll be the judge of that. But I did want to share that background with you. So let's really get to the meat of the conversation today. First question, and I'd really like each one of you to comment on this. Agreement, disagreement with the statement. Everyone talks about measurement-based care in psychiatry, but no one really uses it in their own usual clinical practice. Strongly agree, no opinion, disagree, strongly disagree. So let's see. My God, I know there are more than 5 people in the group. Six people, 7 people, my God. Either there are fewer people. I hope, that in your elections, in the presidential elections and the elections we have in New England, there is better participation than this. Kesh, I don't know. I mean, are people shy?
I have to say people might be shy and too polite.
I see. Well, let's take a look at this. I mean, this is very interesting. So 75%, that sounds better than 6 out of 8. 70, 3/4 if you think that this is talk, all talk, no walk on this. That, people talk about it. It's make big pronouncement statements, but really, this is not happening. A couple of you mildly disagree with it, but the vast majority thinks this is true. It's all talk, nothing real, if you will. Let's go to the next question if we can. If we got next question, yeah. Next question, Rachel, if you could. So the next question is, do you utilize measurements in your practice? Yes, always. Yes, about half the time. Yes, occasionally, never. And the fifth one is an even stronger statement. Of course not. There are no useful measurements in psychiatry. Okay, okay. So looking at the results, if we close the polls, one of you says always, and two of you say, yeah, about half the time, and the 3/4 say occasionally. None of you never use it, and none of you thinks that there are no useful measurements whatsoever. Let's go to the next question if we could. So next question. Those who use, which is all of you now, you use it part of the time at least, those who use specific measurements in the clinical practice, what do you use it for? For all efficacy measures and side effect measures and function. 2, only for side effects. 3, only for efficacy and side effects, but not function. 4, for side effects and function, but not efficacy. And the fifth one, of course, hopefully none of you are going to vote for that because none of you voted for this earlier. As I said, I do not use any measurements to guide my clinical decision making. So please vote now and let's see what we get. Now, this is really an interesting vote. All of you use it. All of you use it to measure all 3 aspects. You use tools that look at efficacy. You also use tools that look at side effects. And you also use tools to examine function. That's great. So let's actually move to the next. Let's share the results if we could. And the last question is this. Those who do not use efficacy, which is, none of you, probably this vote is not there. Those who don't use them, I don't use them to look at treatment response because I don't know if there are any such instruments that I can use. I know there are instruments, but I don't know how to use them. I know instruments, but I don't think they're useful. 2, 4, I've used such tools and I've not found them useful. And finally, I do use instruments for screening and assessment, but do not use them to assess response to treatment. Let's see if there are any, let's give it another 10 seconds. Only 3 votes on this one. Maybe the question wasn't as clear as you might have wanted it to be. But okay, we'll stay with this then. So essentially, a variety of reasons why you don't use tools to measure efficacy. And I guess the others are not voting on this one because they said we already use tools. So this question is not relevant to us. So let's move on to the slides now, if we could. Rachel, can I go back to the slides?
Hi, Dr. Tannen. I believe that you're the one sharing your screen, so you can just advance the slides.
Yeah, okay. So can we shut the poll question off? It's still on my screen.
You may have to close it, but
I got it. My apologies. Again, it's my age, quite honestly. It's your generation does this so well than mine does. So, no point not admitting it. So let's talk about your first patient. I mean, you show up one day and it's a routine day in your practice. You've had to kind of rush to work, and you've got your first 15-minute check, if you will. And so let's start with this. This is a 45-year-old gentleman who comes in for a follow-up visit. He has a 10-year history of a major depressive disorder, recurrent, severe, without psychotic features, has the anxious distress specifier. He's currently doing very well. He's currently in remission. This is his 10th monthly visit. You see him once a month after a 10-day psychiatric hospitalization for a severe depressive episode, which was marked by intense suicidal ideation with a plan. He had a clear plan. He did not actually attempt to do this. He's had 3 prior major depressive episodes, each marked by significant suicidality and anxious distress. He's married with 3 children. He's employed as an engineer, limited social activity, shy and reserved, no other medical comorbidities. And this is what treatment he's receiving. He's in treatment with 20 milligrams of escitalopram. Lexapro is the branded name for it, and 5 milligrams of aripiprazole. Abilify is the trade name for it, per day. No adjunctive psychotherapy or other treatment. He reports that he's doing well, no problems at work or home, is tolerating his medications well without any clear side effects, sleeping well, has fair appetite, interests, other activities as usual, denies any psychotic or melancholic symptoms, denies any suicidal or other aggressive ideation, intent or plan. And this is probably all that you can do in a 15-minute visit, right? And so what do you decide to do? You evaluate the person. You say, well, oh, good. Let's continue present treatment. Let me see him another 4 weeks. By the way, in case you have a problem, this is how you can contact the clinic, and this is how you can seek emergency help should you choose to, should you need it. Now, one of the things in your clinic, though, is the person fills out a PHQ-9. And so, this person had completed a PHQ-9 when they checked in, but, and the nurse comes back to you and say, the patient's gone, made the appointment for the next visit. She comes to you, and those of you familiar with the PHQ-9, there are 9 items on it, as it suggests. And the last 3 items are the following. The total score is 6, and you don't make much of that, but then this is what you see. Well, the 6 points that this person got was A, item I, thought better of dead or hurting himself. Item H, feels slowed down or fidgety and restless. Item G, has trouble concentrating. At that severity, what would you do? Now, by the way, as you think about this, actually, I had a patient like this. Now, I don't see patients in 15 minutes. I have, this has been a policy I've decided not to work at any place that requires me to see 15-minute follow-ups. I have 30 minutes, but even so, this is actually something that happened to me a month ago. And what was my excuse for not having seen the PHQ-9 results before I saw the patient this time? Well, I've been reviewing them before, and the scores had been 1, 2, 1, 2, 1, 2. None of these items stood out. And so on this particular occasion, it was okay. But then when the nurse brought this to my attention, I said, oh boy, I messaged the patient. And as I messaged the patient, he actually responded with a detailed note. I said, I'm sorry, I did not notice what you'd filled out prior to our conversation. Can you share more of this? And please feel free to contact me. And so he did. Actually, he sent me a detailed note. And of course, one of the questions was, if this is what had been going on, why didn't he tell me that he was thinking that he had thoughts of suicide? Well, this is an appointment that you have, and you ask the question, but you don't get into any details, if you will. And as he shared what in the message, he informed me that I have been having these thoughts. I was not having them at that time, but I've had them intermittently, not the immediate week prior, but the week prior to that, I did have them. And then I got into a little bit more discussion. There were some situational factors. There was some restlessness. I had to think about the possibility of akathisia in terms of the combination of meds that he was on. And so essentially, what I'm really sharing with you is there was not an emergency, fortunately. There was information there that should have been explored during the visit, because there could have been a need for urgent action at that time. There may have been need for some actual change because of the fidgetiness, the restlessness that he was experiencing, although I did not see any of that in the course of my interaction with him. And so the question was, if I have this information, and if I utilize this information, then maybe it might have taken me a couple of minutes to explore this, but this is something I should do. I should have explored that information, if you will. So the bottom line is, having a tool is useful. And in fact, that's what happens when I go and see my primary care doc, for example. Even before I see my PCP, I have my weight taken, I have my blood pressure taken. If there are labs that have been ordered, and if there's something out there, that information is provided, my pulse rate, my heart rate, I mean, things of that sort, and my primary care doc has that information available. And essentially, that's useful to my primary care doc in terms of the assessment, if you will. And in this case, this is something that could have been available to me, that was available to me, had I paid attention to it. So we think about some of this as formalities, or it adds 2% to our income, or it's some quality metric that some bean counter, if you will, has instituted. No, it's clinically valuable. It's something that is of great value in terms, allows me to do better in the context of my work with the individual. And actually, if you think about what we do in the course of our evaluation, maybe you have a 30-minute or a 45-minute initial eval, and then you have a 15-minute or 30-minute follow-up examination. This is what you're trying to do. This is what we do every day. We try to basically get a sense of how the person is doing, what the person's condition is, what the diagnosis is, if you will, but more importantly, how the person is doing. And once we have a diagnosis and have initiated treatment, then we want to know in every follow-up visit, well, what's happening to my patient? Is my treatment working? Is my treatment not working? Well, if it's working in part, what's it working for? What is not getting better? What is getting better? And in terms of my treatment decision-making, what should I do? Should I change treatment? Or should I continue the same treatment? And should I add something? Should I change doses of something? Should I stop something? Should I target something else? These are the kinds of decisions we make every day with every patient that we see. And if one thinks about tools and method, if you will, which is what I want to share with you, discuss with you over the second half of the presentation, is in fact there are tools. And in DSM-5, there are different kinds of tools that are available. And if you really think about it, going back to this graphic, we need to find out what the problem might be, or where there might be a problem. We need to then assess that problem, and then we need to see what treatment that we're providing, is that making a difference or not making a difference. And in DSM-5, we have tools for all three. We have screening tools, and that in DSM-5 are so-called cross-cutting measures level 1. And they're separate cross-cutting measures for children and for adults. A series of 21 questions, if you will. They're self-rated. So when the person comes into your clinic, and actually this is what we've been recommending that primary care docs do as well. They basically utilize it, at least at their initial visit, a cross-cutting, have the patient fill this out. It's for the purpose of screening. There may be a problem in this broad area. Then there are tools for assessment. And then, very importantly, and this is where I hope to spend most of my time on discussing with you, are disorder-specific severity rating. That is, I'm being treated for high blood pressure, hypertension. Well, I've got a PCP who treats me for hypertension. In my case, my PCP is a he. He'd better be assessing my blood pressure each time I go to see him, because if he's not, I'm probably not, no matter how wonderful he is, how nicely he speaks to me, how aware he is of my family and my interests and things of that sort. I'm not going to see him if he's not. How does he know what he's doing is making a difference or is the best he can do if he's not measuring my blood pressure? And so the third kind of instruments, tools that one has in DSM-5 are disorder-specific severity ratings that enable provision of measurement-based care. Many of these tools are patient-rated, some are informant-rated, and a few are clinician-completed. And so we'll briefly discuss this. No time to discuss this, but this is an example of the screening instrument that I was talking about 21 questions. And these are the patient, who's come into the clinic, fills these out. And it allows you to look at areas that you might want to kind of follow up on or explore in some detail, depending on where that goes. So this is the level 1 cross-cutting measure tool, if you will. This is for adults, a screening instrument. Then you've got assessment instruments, if you will. But I want to kind of spend most of my time on measurement-based treatment, tools that help you gauge response to treatment, and then discuss a number of vignettes with you that illustrate how that can be of value in terms of clinical decision making. So in this case, I'm going to focus on a patient with psychosis. Okay. Now, the analogy that I would draw is when I'm being treated for diabetes, for example, you periodically get A1C levels, you look at glucose, and you look at other metabolic measures, if you will. They help you gauge the effectiveness of the treatment that you are providing and allow you to make adjustments based on what is actually happening to the individual. They help you individualize treatment, which is something we know is very, very, very important in with regards to what we do in our field. We need to individualize treatment because the same condition looks very different in different people with that condition. The same treatment works differently, has different effects. So it's really critical that we individualize treatment, and we need tools, measurements that, analogous to treatment of diabetes that help us do that. So let's actually get away from the theory and let's look at the tool and then apply it to a treatment of patient, okay? And this is one thing that I would suggest, and this is where my clinician bias is really relevant. I am trying to help my patient, and I'm doing everything I can to help my patient. And sometimes I might miss sight of the fact that what I'm doing is not working or it's not helping. And in my exuberance, in my enthusiasm and desire to see my patient better, I stay on the same thing that's not working. Or I add something that's been completely ineffective. I add something else instead of withdrawing the thing that's not been working and trying something different. And so basically, we all get into what I would describe as clinical inertia. There are certain ways of doing things that we get stuck with. I know that's happened to me. And I've seen that happen to a lot of my colleagues. We all get stuck with clinical inertia, and data, information which is not just based on our subjective impressions, is of value in terms of shaking us from this inertia. So let's talk about two patients with schizophrenia. And these are two patients now with schizophrenia. We'll encounter 6 different clinical situations with them. And we'll think about, what might make best sense, what you might do, and if or whether or not, measurement is helpful. So what measurements are we talking about? And just, just thinking about schizophrenia, in fact, this is true of all psychoses. If you think about schizophrenia, there are at least 6 different symptom clusters or targets of treatment, and they're distinct. They're distinct: positive symptoms, delusions, hallucinations, paranoia; negative symptoms, lack of motivation, reduced social drive, blunting of the pleasure experience; disorganization of thinking and behavior; cognitive deficits. You get broad-ranging cognitive deficits in persons with schizophrenia; mood symptoms. Depression can be so severe in more than half the patients with schizophrenia that you'd give them a diagnosis of major depressive disorder, but for the fact that they have schizophrenia. And motor symptoms. Catatonia is uncommon, but it's only the most extreme expression of motor symptoms in schizophrenia. And why is it important to keep these 6 things separate as we think about persons with schizophrenia? Because there are different brain circuitries, different underlying brain mechanisms that contribute to them. But even more important for a clinician is the fact that they respond differently to treatment. Antipsychotics, the mainstay in the pharmacological treatment of schizophrenia, they're pretty effective for positive symptoms. They're pretty effective for disorganization. They don't do anything for negative symptoms. They don't do anything for cognition. And as far as mood symptoms and motor symptoms are concerned, they can both help and hurt. So depression, we use antipsychotics to treat them, but antipsychotics can also cause depression, neuroleptic dysphoria, motor symptoms, catatonia, for example. We can use antipsychotics to treat catatonia, but antipsychotics can also cause the worst kind of catatonia, neuroleptic malignant syndrome. So why should we be looking at these 6 different aspects uniquely? Our patients have different admixtures of them. And as we treat them, they might be going in different directions or not. They might be going in the same direction, but it's important to assess them separately. So in DSM-5, there is a very simple tool, to assess this. It takes about 2 minutes. There are 8 items that you score, and you score each of these on a 0 to 4. 0, that thing is clearly absent. No question at all. It's not present. 2 to 4, it's clearly present. 1, I'm not going to bet my house that it's absent, but I'm not going to bet my house that it's present either. It's somewhat equivocal. That's a 1. 2, it's clearly present but mild. 3, it's clearly present but moderate. 4, clearly present and severe. And the 8 items, 2 of them are positive symptoms: hallucinations, delusions. 1 of them is disorganization, disorganized speech. 1 of them is motor, abnormal psychomotor behavior. 1 of them is negative symptoms. 1 of them is cognition. And 2 of them, mood, you've got to separately assess for depression and mania. Now you look at these items and you say, that's interesting. Okay, that kind of looks good, but isn't this kind of soft stuff? I mean, can you measure these things reliably? And the answer is pretty reliably. There've been studies doing it, but more importantly, if you look at section 3 in DSM-5, the manual, you'll see anchors for each of these on a 0 to 4 scale, how they look like. And even more importantly, when you begin using this instrument, you will become reliable with yourself. And that's what's most important. You want to know, using a somewhat objective scale, what's happening to these 8 different elements, if you will. So let's actually get to the clinical vignettes, okay? The first clinical vignette. So this is the scale that we're going to be using, 8 items, 0 to 4, and I'm going to share data from the scale, with regards to these 6 clinical scenarios, okay? So let's talk about Alex, and the first 3 clinical scenarios are with regards to Alex, okay? This is the 26-year-old gentleman with schizophrenia. He's presented with his first episode of psychosis. Shows up in your clinic, you've done a detailed assessment, and in the interest of simplicity, I'm just going to give you 3 items that might be most germane in this case, in this vignette, to think about treatment decision, okay? So let's start with the first vignette. 26-year-old gentleman with schizophrenia, first episode of psychosis. He comes into you, you've used this instrument, delusions of 4, hallucinations of 4, negative symptoms of 2. And you start this gentleman on risperidone, 2 milligrams at bedtime, okay? And essentially, he comes back to you in 4 weeks, and delusions have gone down from 4 to 1, hallucinations have gone down from 4 to 1, negative symptoms have gone down from 2 to 1. You don't observe any EPS, no akathisia, no other notable side effects. And now you've got a decision to make. What do you do? So Rachel, let's get the question, if you will. What would you do? So what would you do at this point? Continue present treatment without adjustment and address other needs of the patient. 2, on 2 milligrams of risperidone per day, let me increase the risperidone to 3 per day. Well, doing very well. So let's reduce the dose of risperidone to 1 milligram at bedtime. Let me add an anticholinergic agent. So please vote now. Please don't be shy. This is completely confidential, so I won't know who's voting for what. Only 4 votes. Oh my God. Kesh, I'm hoping New England has a better turnout in the next presidential election. We got, in any event. So let's close the poll now. I would do what the majority of you suggest. The person's doing well. It's been 4 weeks that this person's been on this medication. First episode, in terms of reduction, things of that sort. There's time for that, and not right now. This is not where I would, but that certainly doesn't need any increase in dosage, and if the person doesn't need an anticholinergic, I don't want to add an anticholinergic because that can have side effects, and this person doesn't need it right now. So I would continue present treatment without adjustment and address other patient needs. Now let's look at Alex again, and a different situation with Alex, okay? Same thing, starts off exactly the same. He starts off delusions 4, hallucinations 4, negative symptoms 2, and you start him on risperidone 2 milligrams at bedtime. Comes back 4 weeks later, delusions have gone down from 4 to 3, hallucinations have gone down from 4 to 3, negative symptoms, have gone down from 2 to 1. Again, no observable EPS, no akathisia, no other side effects. It's been 4 weeks on 2 milligrams of risperidone. So Rachel, let's actually have the next question. What would you do? Same choices again. 4 weeks, gone down from 4 to 3. Let's continue the present treatment without adjustment, address other patient needs. Increase dose to 3 milligrams at bedtime now. Now let's decrease it to 1, add an anticholinergic agent. So let's give it another 5 seconds. A little better turnout this time, 4 rather than 3 votes. Well, I'll take that. A good trend, if you will. I would increase the dose of risperidone from 3 to 4, but for those of you who say, let's give it a little more time at 2 milligrams, not a completely unreasonable thing to do either, because the person is showing some improvement. And if the person is not significantly distressed or at risk of self-harm or other things on account of the psychosis, it'd be a perfect, and it's the first episode patient, it would be perfectly reasonable to keep them at 2, although I might be inclined at this point to increase it to 3, although there'd be other factors that I'd be thinking about. So, okay, fair enough. Now let's look at the third scenario. Okay, same thing, Alex again, but now something different. Same thing, he starts off exactly the same. Delusions 4, hallucinations 4, negative symptoms 2. And so you start him, first episode again, you start him on risperidone, 2 milligrams at bedtime. Now, comes back in 4 weeks, and now delusions have gone down from 4 to 1. Hallucinations have gone down from 4 to 1. But negative symptoms have gone up from 2 to 4. No observable EPS, no akathisia, no other side effects that you notice. Now, what would you do? Rachel, let's get this choice now. Again, the same choices. What would you do? Delusions have gone down from 4 to 1, hallucinations from 4 to 1, but negative symptoms have gone up from 2 to 4. What would you do? Continue present treatment without adjustment or address other patient needs. So no change, essentially, is what 2 of you are suggesting. 1 of you is suggesting, with the increase in negative symptoms, you would go up on the dose of risperidone to 3. And 1 of you is suggesting, 2 of you suggesting that, and 1 of you is suggesting maybe decrease the dose of risperidone to 1. Actually, I would do the 4th. And let me share with you my thinking on this, okay? The first thing when I see this patient, delusions have gone down from 4 to 1, hallucinations have gone down from 4 to 1, and negative symptoms have gone up from 2 to 4, the first thing I do is I scratch my head. And I'll be honest with you, I've lost a lot of hair doing that. So that's the first thing I do. I say, what the heck is going on? I repeat the measurement because I'm not sure I measured it correct. Okay, I say, let me just do this again. Is this really what it is? And after I finish scratching my head, and I basically have made sure that this is exactly what the numbers show, I say to myself, I just realized EPS can exacerbate negative symptoms. So maybe this is EPS. But I examined the patient. There was no cogwheeling. There was no tremor. There was no motoric restlessness. I didn't see any of that. But yeah, the patient had severe negative symptoms, and I could see it. The face was blank. The facial expression was, I couldn't see any facial mobility, if you will. So yeah. Now I'm thinking, what might be going on? And as I lose a few more hair, I realize, oh boy, this might be akinesia. This might be akinesia, which is easy to miss, because akinesia is reduced movement. As you know, bradykinesia is a common symptom of Parkinson's. One of the things that we don't think about with regard to EPS with antipsychotic treatments is akinesia. And actually, if you think about the newer generation atypical antipsychotics that we use a lot more often now, the things that we're more likely to see in terms of EPS are in fact akathisia and akinesia. In akinesia, you don't see anything happening. You see the absence, you see negative symptoms, basically. And so as I scratch my head, I say, I'm not sure it's EPS, but it may be. I'm not going to reduce the risperidone because this improvement is fragile. It's just been 4 weeks. This person has been on an antipsychotic, 2 milligrams risperidone per day. I'm not going to do anything that might destabilize him or her at this point. And so I'm just going to keep this person on the same dose of risperidone. I want to know if, in fact, it's the EPS that's driving the negative symptoms. So I'll give them a brief trial of an anticholinergic. My preferred anticholinergic agent is piperidine. Too long a discussion, or echinetone, too long a discussion about why I choose that. But choose your anticholinergic. You don't have to use a high dose, but use an effective dose, if you will. And you give it a try for a week, okay? You don't try it indefinitely. I will not keep my patient on an anticholinergic long term. It causes
So,
bad.
Rajiv, if I may ask, is it possible that this patient got depressed?
It could be. No. So that's the reason, a great point. So that's the reason, I mean, I didn't give you that's why it's really important to look at all the 8 items, if you will. So it's really, really important to look at all 8 items. And just for the simplicity of presentation, that's why I'm giving this. So let's assume this is not, it could be. You're absolutely right. We don't know it's EPS. It could be depression. It could be some situational, environmental change. I mean, it could be a variety of different things. But in this case, just for the purpose of illustration, I'm sharing this with you. It's not, let's assume it's not depression, but that's a great point you're making, Dr. Keshwar. So let's get back to this. What would I do with the anticholinergic? I'd use it for a week. If in fact the negative symptoms get better, then I know it's EPS that's driving this. And as I know it's EPS that's driving this, I'll say now maybe I need to think about reducing the dose of risperidone or trying something different, because I do not want this person to be on an anticholinergic long term. But I know what's driving this increase in negative symptoms. And the only reason I was triggered to akinesia, I would have missed akinesia. Because the person's doing well. So why, yeah, it looks a little flatter, but it's part of recovery, things of that sort. I could pass it off for many other reasons, if you will. But having that measurement helped me at least think about what's going on. And now I have a method to kind of go through this, if you will. So that's what I would do, if you will. Let's take a look at another scenario. This is, let's see what happened here. This is Elena, okay? And Elena now is, again, first episode, 25-year-old lady with schizophrenia who presents with the first episode of psychosis. By the way, the fact that risperidone is the antipsychotic being chosen here, don't interpret that to mean that's my preferred antipsychotic, if you will. I'm just using it for illustrative purposes, because you'll see, because it also allows for some other discussion, which we may not have the time for. So let's not go there. Let's just stay with the vignette. So Elena is a 25-year-old lady with schizophrenia who presents with the first episode of psychosis. Again, delusions 4, hallucinations 4. And since Dr. Keshwan, you wanted depression, here it is, depression 3. Okay, and again, I'm only presenting 3 items. I mean, I want to look at all 8 because they're all relevant. But in this case, I'm just presenting 3 for the purpose of simplicity. So Elena comes in, first episode, schizophrenia 4, delusions 4, hallucinations 4, depression 3. I start her on risperidone 2 milligrams at bedtime. And she comes back 4 weeks later. Delusions have gone down from 4 to 1. Hallucinations have gone down from 4 to 1. Depression has gone down from 3 to 1, 1.5. No EPS, no other antidepressants. So if you don't mind, Rachel, Rachel, yeah, thank you so much. What would you do? Would you, risperidone 2 milligrams doing well, let's just continue it. Increase the risperidone to 3, decrease the risperidone to 1, add an antidepressant, because although depression is improved from 3 to 1.5, there's still some depression, so let me add an antidepressant. So let's see what you do. Okay. Let's end the polling. Okay. So most of you would continue same treatment, no change. One of you would add an antidepressant. Well, let's come back to that. We'll come back to this scenario as we look at 2 other possibilities with Elena. And so again, Elena, same person. So in this case, as you mentioned, most of you would continue no change, and one of you would add an antidepressant. Well, let's look at Elena again, but something different happens to her this time. So again, same clinical essential scenario. Delusions 4, hallucinations 4, depression 3. You start risperidone 2 milligrams at bedtime. 4 weeks later, this is what you see. Our delusions have gone down from 4 to 1. Hallucinations have gone down from 4 to 1. Depression has remained at a 3. Not gone worse, not gone from 3 to 4. It was 3 before, it's 3 now. No EPS, no other side effects. Rakal, if you don't mind putting on, thank you so much. My God, you can read my mind, and this is scary. So let's see what you do now. Same options, same treatment, continue same treatment, no change. Increase risperidone to 3, decrease to 1, add an antidepressant. And for whatever reason, good, okay. So 2/3 if you say add an antidepressant, and 1/3 says, no, continue the same treatment without adjustment. Well, what would I do, okay? And the bottom line is, I would agree with the majority in both cases, okay? Now, what's my thinking? Well, 3/4, so, you know, those who would start an antidepressant right at the outset have a good argument to make. You know, why would you not start to forget 4 weeks? Why wait 4 weeks? Why didn't you start this person on antidepressant along with the risperidone right at the outset? Their depression was 3, right? And so if the depression was 3, you want to treat the depression, don't you? And the answer is yes, but I will start an antidepressant for the following reasons. One, this, if I've done due diligence, come up with a good diagnosis, schizophrenia, first episode. Well, depression is not uncommon at all during an acute exacerbation of schizophrenia. In fact, and once delusions, hallucinations get better, in about 3/4 of persons with schizophrenia, depression gets better. So as psychosis improves, depression improves. And so they don't need an antidepressant. So, well, why not give them an antidepressant to begin with anyway? What's the harm? Well, there is harm. The harm is that antidepressants interact with antipsychotics. They can compromise their efficacy in some patients on positive symptoms. There are significant drug-drug interactions. They complicate the use of antipsychotics, modifying their blood levels, etc. And they have side effects of their own, some of which are additive side effects with the antipsychotic. And so for the 3/4 of individuals who do not need an antidepressant, whose depression would improve anyway as psychosis improves, giving them an antidepressant will harm them, will hurt them. And so that's why I don't start them. But if depression has not gotten better and psychosis has already improved, then in that case, I will add an antidepressant because now I've identified the 1/4 of patients who need antidepressant treatment to help their depression. Now, at 4 weeks, would I do it? Would I do it at 6? Again, it depends on the circumstances of the patient because if depression, for example, had gone down from a 3 to 2, I'd seen some movement, I might give it more time. But if it stayed the same, I would probably add an antidepressant. So that's how I would think. And that's my clinical thinking, if you will. So the bottom line here is, in closing.
So, Dr. Tandon, we have about 4 minutes left. So if you want to wrap up and give the audience some opportunity to ask any questions, that'll be great.
Sure, absolutely. So the bottom line, the last minute, I mean, let me just take 1 minute. I think, we think about the absence of tools in psychiatry. We do have tools. We need to be very mindful of what these tools do. Some are very good for screening, some are useful in assessment, and some are very useful in monitoring treatment response. They're not overly complicated to use. They are valuable. And if you were to ask me, do I use them? Yes. Have I gotten all my faculty to use them? No. Have I gotten all my residents to use them consistently? Honestly, no. But that is my endeavor, not because they're 100% useful in every single patient, but they are useful, they are simple to use, and they help me provide better care, which is the bottom line. So let me stop at this point, Dr. Keshwat, because, one thing I would share with you, since again, Dr. Keshwat,
Losing you.
my age with you, is the fact that one of the things I've learned in psychiatry and medicine in general is the practice is very simple. And although we have pretty good medications, treatments in psychiatry, we can be doing a lot better in using them more effectively. And the key in my mind is targeted treatment, measurement-based treatment, so that we can optimally individualize care. Let me stop here.
Thank you very much, Rajiv. That was a crystal clear presentation of some really wonderful tips for the practicing clinician. So let me see if there are any questions from the audience, and I'm looking at the chat box to see if there are any. I don't see any questions in the chat box. Okay, so I have a couple of questions, Rajiv. What would, in your mind, be the best tools to use as measurement-based tools for psychosis and for depression? So the way I think about it is, in order to be effective, a good tool has to be easy to use. It has to be brief, and it has to be sensitive to change. It has to be reliable and valid, and should be easy to document. So can you give maybe one or two tools for this group for each of the conditions, that major psychiatric conditions that we treat?
So a good reference that I would point to is look at section 3 of DSM-5, because there's a whole, directory of tools, if you will. But let me be at a clinician level, simple clinician level. Psychosis, it's relatively easy because this instrument that I presented to you, it's called SCORS, SCORS. It's there in DSM-5. They've got the anchors defined. And this is a tool I know. There have been reliability studies on it. It's a useful tool that we utilize in our clinical practice. For psychosis, this is what I would suggest. And hopefully, the illustrations the case vignettes that I illustrated, indicate how it could be utilized, applied in clinical practice. In depression, the answer is a little more complicated. And the answer is complicated because I would suggest using two sets of instruments, if you will. The PHQ-9 is an instrument that we all are using more and more and more. And it's a useful instrument, but it's a screening instrument. It is not a severity rating instrument. So if you want to assess response to treatment, overall treatment, then the total scores and things of that sort may not be the best instrument. The total score is really not telling you much, but it's still a very useful tool in usual clinical practice, as we discussed, in the first vignette at the outset of the presentation, where it can tell you, let me pay a little more attention to this particular aspect of what's happening to the patient, because there's something happening there that I need to better understand and maybe do something about. Now, there are tools for depression, which I would recommend. I've always found the Hamilton to be, the Madras is not a bad instrument, but that takes a lot more time. It's a little more cumbersome to do. It takes a lot more time. There are self-rating instruments like the Beck. I don't find that particularly useful in terms of overall severity. There's a better instrument called the Carroll, which people are less. So I can share with you a number of these instruments, but very simply at the level of clinical practice, my suggestion would be simple. use the scores for psychosis. As far as depression is concerned, continue using the PHQ-9, but use it as a guide to what is something else that I might need to be looking at, paying a little extra attention to on this visit. Don't use it as an instrument to measure response to treatment, if you will, because the total score there doesn't mean much.
Yeah, thank you very much, Rajiv. And on behalf of all of us, I would extend my appreciation to you. And I will follow up with maybe sending some literature to this group on measurement-based care. And Rajiv, I'll follow up with you on that.
Sounds good.
Thank you so much. Have a wonderful day, rest of the day.
Thank you, everybody.
Thanks.